Everybody, thank you for your participation. Tonight is the second module of the plan about the MLS treatment on equine pathology. Tonight the topic is tendinitis and desmitis, and the speaker will be myself and Dr. Tatiana Falconi. Just for your information, she degree at the University of Milano. She is doing she is a speaker at the courses organized by Professor Denois. She get a specialty in equine medicine in the University of Medicine in Milano, and she degree in veterinary. She get a degree in veterinary acupuncture, and she is one of our clinical trainer. Now, as just a brief description of the organization of the webinar, all the modules, we will talk about a little bit about the laser principle, something new every time, a little bit about what is specific of MLS laser therapy, and of course, the majority of the webinar will cover the clinical focus, which is tonight, tendinitis and desmitis. Then I invite you to put all the questions in the chat, and we will make sure to answer you as soon as possible, preferably at the end of the webinar. Okay. So, about a little bit about the laser. Last time we talked about what is a laser, what is the, let me say, source, about the source, especially MLS is a diode laser. What is the difference between high power and low power? MLS is an high power laser. The emission, MLS is as a continuous and the pulsed emission, the benefit of the pulsed emission. And tonight, we talk about the laser interaction, and basically the laser interaction, all the laser are in the infrared range, which is not visible. That's why you need to have the goggles to protect the eyes, and the goggles usually there are the indication about which wavelength can protect. I mean, we are not talking about standard sunlight goggles, but each laser need to have a specific goggles, because specific goggles protect for specific wavelength of emission. So we are talking about infrared range. We talk about the therapeutic windows. So all the laser, the majority of the laser are set, the wavelength are set in this window, because in this way we can get effect. And now we talk about the fact that, of course, the wavelength is important, and the power is important, because the wavelength can carry the power in the deep structure, and the power is important because more power means more effect. Of course, not all the wavelength can reach deep structure, but depending on the wavelength, we can reach different level of the skin, of the tissue. So the trigger factor of the penetration is not only the power, but is the wavelength, which is the carrier of the power. What else? Here we have a table that different wavelength, different penetration. So it's clear that the power is not the key factor. It's important the wavelength that can carry the power deeper. In our case, we are in a range of 3 or 4 centimeters, still with the 30% of the initial power. So we can go even further in the structure. What is MLS? We talk about what is specific of MLS, the combination, the synchronization, in order to, and the optical group, in order to have an homogeneous treatment in the area. So all the volume is treated homogeneously. We have 2 emission modality, continuous and pulsed. Pulsed because in this way we can do the treatment step point by point without any risk of thermal damage, and we can use the power at the maximum level. Okay. We are still in the therapeutic window, so basically the therapeutic window is a window where, yes, we still have absorption by the main chromophore, hemoglobin, water, or melanin, but at the minimum level. Why? Because in this way we can give the possibility to the photons to reach the deeper level of the tissue, of the body segment. Not only to stay, not to be stopped on the superficial layer of the skin, which are very rich of water. So in this way, we can make sure to spread the photons in the muscle, in the tendons, in the joint. This is basically our concept. So we send a very energetic package, pulsed package. Of course, the temperature, which is the black line, increase, but between one package to the next one, we give time to the tissue to disperse the energy that is not absorbed by the tissue itself. So in this way, there is no accumulation of power, there is no increase of temperature beyond the thermal damage, so you can use the power at the maximum level without any risk. We have a patent, different kind of applicator. And what is most important is that we can do two different application modality, point by point or scanning. Of course, the point by point modality is much better. Why? Because basically the system gives you exactly how much energy you deliver, you provide in a specific point. So basically, the scanning can be good for certain pathology, but when you have, for example, around an articulation, around the joint, doing the spreading the energy point by point, guarantee you about how much energy you provide in a specific part of the body, part of the articulation, which is clearly described in the user interface when you use the laser, because we give exactly, for each point, we give exactly how much energy you provide in that point during the treatment. Okay. This is a test that we perform, that even staying steady for 20 minutes, there is no accumulation of energy, and there is no, so basically the temperature never overcome the 43 degrees in order to reach beyond the 45 degrees of, which is the thermal damage. So with MLS, you are guaranteed that you can use 100% the power, which is the glare, without any risk of burning, even in the point-by-point treatment, staying steady in the area. Okay, so you don't need to do a fast scanning, but you can, in order to avoid a thermal damage, but you can do the treatment with a slower scanning or with staying steady in the area, which is the great benefit of MLS. Now I pass the part to Dr. Falconi in order to cover the clinical focus of tonight. Thank you, Dr. Falconi.
Hello to everybody. Now we will concentrate on this issue, tendinitis and desmitis. I think these are very interesting for equine vets. So let's go on. We start talking about laser as a physical therapy that can affect biological processes in the body. But which are these processes? Anti-inflammatory, anti-edema, analgesic, and biostimulation. Of course, we can need all of these when we treat tendons and ligaments, but we have to be aware which is the status, the pathologic status of the tendon and the ligament in that moment. So to choose, in order to choose the best protocols for healing. we will talk about frequency. What is frequency? Is defined as the number of light pulses emitted in 1 second. The unit of measure is hertz, and each frequency stimulates certain organic functions. We will see that when we treat tendons and ligaments, we will use almost always the same frequencies, because tendons and ligaments respond very well to the frequency that we have chosen. And it is possible to use also continuous wave when we need to have a very strong effect and a very strong power, because we reach the maximum power of the laser. We will talk about dosages. The therapeutic dose is defined as the amount of energy in joule per unit of surface. So we talk about joule per square centimeters. So which are the frequencies that we will use most in the case of tendonitis and ligament damage? So 10 hertz, 18 hertz, 73 hertz, 292, 584 hertz, sometimes 1168, and continuous wave. So 10 hertz is more for the acute situation of edema, 18 for the acute pain, 73 is for the insertion of the ligaments on the bone, or where there is, yes, the insertion of tendons and ligaments on the bone. 292 is the best frequency for joints, tendons, and also synovia. 584, it's the frequency that is very useful when we have to repair soft tissue lesions. So you will see I use it a lot. 1168 is a frequency that I use when the pain is very focused on a point, and if there is no response on 18 hertz of the acute pain. So I have the opportunity to use another frequency, that is this one, which is typical also for the trigger points. And continuous wave is when we need to give a big amount of energy. So let's go deeper. The handpiece I use, of course, is the small one, because I want to come in touch with the skin, and I want to be really aware where I'm treating and how much energy I'm giving each point. I will register everything I do, so I can eventually think about what I did if I don't reach really what I expected to be. So let's start. I will start with the suspensory ligament, and afterwards we go to the tendons. So suspensory ligament, we can have branch injuries, we can have injuries in the body, we can have injuries in the insertion. So we have also studied that the lameness and the pain and the ultrasonographic improvement following high energy laser treatment is demonstrated. So let's go on. So acute desmopathy of suspensory ligament branch. It causes mild to moderate lameness of the affected limb. Clinical signs are more visible in case of injuries of the body and of the branches rather than proximal insertion of injuries. Everybody of us knows that proximal insertion can be very tricky to see until there is a bigger damage. So We can have in acute desmitis, we can have local heat, mild edema, pain on palpation, rounded contours and margins on visible on ultrasound, and increase the volume of the ligament. So we will talk first of all of the acute inflammation phase. This after trauma lasts 2 to 10 days. So we have immunomodulators, pain, microhemorrhage, edema inside the ligament. We can use cold therapy, rest, bandages, and so on, also systemic anti-inflammatory drugs. But first of all, in the acute inflammatory phase, we needed to have the control of pain and the edema reduction. So I will use one treatment a day with very low energy dosage. I talk about 1 joule per square centimeter. So which are the protocols? For acute pain, 18 hertz, 1 joule per square centimeter, edema, 10 hertz, 1 joule per square centimeter. As I told you before, if you don't have a good control of the pain with this protocol, you can use also the protocol with 1168. Point by point application. Normally on these areas, I use this kind of application. And I apply not only on the injured area, but also on the surrounding areas. If I have, for example, a lesion in the middle of the suspensory ligament, I treat all the ligament from the insertion to the proximal insertion to the insertion of the branches, not only the point where there is the lesion. Why? Because I need to stimulate a good blood supply from the periphery. So the result will be faster. Here an example. This was an acute lesion of the lateral branch of the suspensory ligament in a show jumper. He was already 14 or 15. There was a lot of edema, a lot of pain, and the reduction of pain was to see from the very first application. These are the pictures of the pre-treatment ultrasound. So the protocols I used were edema, acute pain, 3 treatments per week, point by point. Here another case of a lesion in the hind limb, here in the front limb, different horses. So in the acute phase, from 2 to 10 days after injury, the protocols will be edema and acute pain, because I need to control the pain and the edema as first. After this phase, I arrive in the subacute phase, so from 10 to 60 days after trauma. The platelets form a net to start the healing process. We have the formation of type 3 collagen fibers. We can start with the hand walking. So in my protocols, I want to start as soon as possible with moving the horse. I don't want the horse resting too much in the box, in box rest. We can add the swimming, water treadmill, and small paddock eventually. It depends also on the character of the horse. But what I need in this phase is the stimulation of fibroblast activity, the stimulation of blood circulation. I treat normally every 2 days, and I make a checkup ultrasound after 21 days. So the acute phase, I treated with edema acute pain. In the subacute phase, I change my protocols. I can continue with edema if there is some edema resting, but then I use acute tendinitis and the protocol with the 584 hertz. You find it as acute osteoporosis, but what is important is the frequency that you use, always point by point. So the results here, after 20 days, we have a good result, ultrasonography. We have a big reduction in the edema. We have fibers to see, and the horse could start to be brought to a small paddock. And this was only after 20 days, 7 treatment. And after other 2 months, it was possible to start the normal activity of the horse, and he returned to be a show jumper within 3 months. So I think never a recidive was seen on this lesion. So it was really very interesting. Other cases here in the insertion of the branches. In this case, I have also a lesion in the sesamoid bone. So the treatment I used was edema, acute tendonitis, and bone injury, 73 Hertz, because when there is the lesion near the insertion of the bone, I use also this frequency. And in this case, I added also medical therapy with the biphosphonates. I treated 3 times a week for 2 weeks, and afterwards 2 times a week for 1 month. Walking for the first 3 weeks, afterwards walk and trot. So this horse turned to it was a standardbred, turned to normal activity and racing without any problem again. Here another a different lesion, a subacute lesion of the medial branch of the suspensory ligament in a front leg. It was a recidive. And again, which protocols? Edema, of course, we see there is a lot of edema, acute tendonitis, and 584 Hertz. Here, 3 treatments a week for 1 month. 3 treatments because it was an old lesion, a recidivity, and so I wanted to be strong with the energy and very constant with the giving my supply. Hand walking until lameness is healed. In this, after 1 month of treatment, it was a remodeling phase, which was already very interesting. And I used the protocols of chronic tendonitis and continuous wave. So 1 treatment a week, not more, for 4 weeks, and progressive increase of activity level. So, of course, correction of shoeing, and we had the return to previous activity after 3 months, and no recidivity till now. So also this case responded very well to laser therapy, even if it was a recidivity of an old lesion. So here I have a subacute lesion of the proximal insertion of the suspensory ligament. This was a front leg, yes, and a standardbred. Again, chronic tendonitis, because it's together with regeneration, 584, acute tendonitis, and continuous wave. Not all in the same session. These are the protocols I need, but I change each time. I can put 2 protocols together, but not more. So this injury was associated to convalescence from superficial flexor tendon injury. So the therapy was done 3 times a week. After the subacute phase, we go into the chronic phase from 60 to 120 days after trauma. Sometimes it could last up to 1 year. There are a lot of differences between horses, between the breed, between from one horse to the other. The remodeling phase can vary in the capacity of healing. So in this phase, we have the maturation of collagen from type 3 to collagen type 1. And we need the realignment of fibers and the remodeling of the fibers. Of course, controlled and progressive exercise is mandatory, so it's not possible a good healing without a good movement in protocols of rehabilitation. So we need to promote remodeling, stimulate strengthening the fibers. And it is important to check the possible inflammation related to retake of activity. This is a very important point in the rehabilitation of the horse, because if we start too early in a strong activity, we can have again an inflammation of the structure. So we can control this inflammation each time after an increase in load of work. So in this phase, normally I treat 1 or 2 treatments a week, normally 1. And then I continue with my checkup with the ultrasound, just in order to know what is going on and to choose the best protocols, the best frequency for the case. So which are the protocols in this chronic phase? We have chronic tendonitis, 10 Hz. As you see, we have 2 joules per square centimeters, not 1. So we increase with the energy given to these structures. And continuous wave, we can use 1 or 2 joule per square centimeters. Normally, I don't use these 2 protocols together because there is a bigger amount of energy. So this in this case, this was a horse used for tracking, quite old horse. We have an increase in the diameter of the suspensory ligament or at the insertion, and also a calcification inside the body of the suspensory ligament. So it was a very chronic situation. And there was sometime lameness and sometime not. So we checked and we arrived to this diagnosis. Of course, the protocols were this one, and after 1 month of treatment, there was no recidivity anymore. There was no lameness again. Of course, we have the diameter was still bigger of a normal ligament, and the calcification was inside, but the pain and the inflammation were not more to evidence. Here, another clinical case of the insertion of the suspensory ligament in a hind limb. So they gave him only rest. There was a grade 1 lameness, not always noticeable. They give them rest, reduction of work, and after 3 months, there was not really a big difference. There was, in these 3 months, they did not use laser. So after that, they started with laser, with acute tendonitis, chronic tendonitis, and wound, which is continuous wave, with moderate but continuous activity. After 1 month, we could make the first attempt of speeding up, and there was no recidivities reported anymore. The horse raced without any other problem and difficulty. So it was interesting to see that without a real good therapy, there was not changing in the appearance of ultrasonography of the insertion of the suspensory ligament, and after only 1 month of treatment, it was possible to speed up with the horse. Another case, it was a very big lesion inside the body of the suspensory ligament, acute grade 4 lameness, a lot of edema and pain in all the area. In this case, we used PRP, and it was possible also to use stem cells, which is my protocol in these cases. I prefer the first week, the very acute phase, to control edema and pain. Afterwards, I use the PRP or stem cells, as you like. I wait for 1 week without laser therapy, and then I start again with my therapy with the protocols for the acute or subacute situation. Okay. So this was just some reminders of what these lesions are. So in this case, everyday pain for 7-day pain and edema, then PRP preparation and ultrasound guided injection inside the anechoic area. In this case, I used 3 points of injection, bending and post-rex, no laser therapy for 1 week. And then subacute phase, the protocols for acute tendonitis, regenerative and edema, 3 treatments per week, point per point for 4 weeks, and then an ultrasound check. In these weeks, the horse was worked 10 minutes a day. We see already a good, starting a good, reparatory process inside the body of the suspensory ligament. This was 4 weeks after the severe injury. Now we go to superficial digital flexor tenon lesion. Here we have a peripheral lesion in this superficial flexor tenon. Again, in the acute phase, protocols are for pain, edema, and here, edema and acute pain, cold treatment, bendings, and so on. 3 treatments per week for 2 weeks, point-to-point modality. In the subacute phase, I introduce the protocols for acute tendonitis because I don't have pain anymore after 1 week, and regenerative or acute periosteitis protocols. 2 treatments a week for 3 weeks, point-to-point modality. This was the control after 4 weeks, I think, yes. So in this case, I continue with the protocols for the remodeling phase. So chronic tendonitis, I want to give strength to the structure, and while there is an increase in load of work, I can use continuous wave, but not more than once a week. And yes, I use laser therapy once a week for 4 weeks. Actually, currently there is no recidivity and the horse runs regularly, so also with a high speed. Here, something different. Again, a very big lesion. There was almost nothing to see anymore from the superficial flexor tendon. For the first week, it was important for me to reduce pain and edema. absolute box rest because the horse was really very painful. So every day the protocols for pain, 18 Hertz, and edema. After this PRP preparation and ultrasound guided injection, post rest for another 7 days with no laser therapy. And then I started again with laser therapy with edema, acute tendonitis, and acute perostitis, 2 treatments a week. So there was the complete recovery of the horse. I continued the laser therapy also in the chronic phase with the chronic tendonitis, 2 joules per square centimeters, continuous wave, and one time a month until control. So at the moment, I don't have any recidivity. So it was 2018, and it's now 3 years that it's no problems anymore to this tendon. So I want to show you the case of a deep digital flexor tendon lesion. Here it was in the periphery. It looked almost like perhaps an hematoma, but the way of thinking is always the same. Acute phase, we use acute pain protocol, edema, 3 treatments per week for 2 weeks, single point modality. And then in the subacute phase, I introduce the other protocols for acute tendonitis, regenerative or acute perostitis, 584, 2 treatments a week for 3 weeks. And so the appearance reminded more a peripheral hematoma. Tendon splitting was suggested, but has not been accepted by the owner. There was no pain after 1 week, and the horse was walked under saddled. So I introduced the protocols for hematoma and for wound 2 times a week. And there was here a good healing process with slightly non-homogeneous scar tissue here, but absence of lameness and gradual increase of workload, also trot, and complete retake of activity tracking after 6 weeks. No recidivity at the date. So we go through an example of lesion of the Czech ligament. This was a very big lesion. Again, the first week in the very acute phase, I treated 3 times a week with edema and acute pain. And the second, third week with the 292, 584, and 10 Hertz, 1 joule per square centimeters. In this case, I made only 2 treatments per week because the horse was quite far away. So I could use all the 3 protocols together because there was enough time between one treatment and the other. And it was possible to use this amount of energy. There was no other treatment than laser Mls therapy made. No anti-inflammatory drugs, no bandages, nothing else. And here we can compare the difference. And it was exactly 1 month after. So using only a laser therapy. So it was quite interesting. It was possible to increase the work. The load of work. The horse was not lame, and of course we continued with laser therapy also in the chronic phase to help with the remodeling of the Czech ligament. And after 4 months, I think, the horse, it was a show jumper, went in the shows again. So not really very high level, but it was possible. Here, just a very unusual case. We have the contemporary lesion of the superficial digital flexor tendon and the lateral branch of the suspensory ligament. So I don't know if you had something like this in a horse. To me, it happened only one time that they were together in the same leg, but the treatment was exactly the same. I mean, if it is the acute phase, I will use the protocols for the acute phase. And I treated for 2 weeks, and then I started with the acute, subacute phase protocols. And also this case had a good result. It needed some more time, yes, because the lesions were quite big and on 2 structures at the same time. So what to say, what can we do with Mls therapy on tendons and ligament? We can have the induction of cell differentiation, maturation process in which cells specialize to show the characteristic function of the tissue they belong to, and observed in the mesenchymal cells. We have the magnification of processes concerning cytokines. We promote reparative and regenerative processes, and the remodeling of the connective tissue. This is due particularly for the photomechanical effect of the laser therapy, which is very effective on the interstitial space of the tendons and on the matrix. So we increase the extracellular matrix, the production by fibroblasts and chondrocytes, but fibroblasts is the case. We can have the induction of formation of very ordered arrays of fibronectin fibrils. This is true, but we need also a correct way of load of the horse. So it's not enough just doing laser therapy, but we need also some correct work. And we have the promotion of angiogenesis, which is very important in these structures where the blood supply is very low. So some suggestions. First of all, accurate diagnosis and regular ultrasound checks. Write down all the rehabilitation protocols with expected dates of treatment, timing, types, duration, modalities of exercise, MLS protocols used. So you will write down the frequency and the energy and how many points you used in order to keep a diary where the owner may flag the expected protocol and write comments. Absolute stall rest is recommended only for the strictly necessary time in the very hyperacute phase until pain is under control. Afterwards, start exercises to facilitate elasticity, flexibility, and contain the formation of scar tissue. In my experience, if it is possible to start the use of laser therapy in the very acute phase, the formation of scar tissue is very, very, very low. If we start laser therapy when there is already a chronic situation, so we cannot help too much with the reduction of the scar tissue. So it will stay bigger in diameter, the structure. So small paddock as soon as the conditions allow, based on the clinical and the horse the clinic and the horse temperament. And keep in mind, each horse is different, so it's very important to check with ultrasound the results we have reached. Normally, I do ultrasounds each 21 to 30 days in the horse until he's okay. So, thank you. I hope I gave you some good suggestions, and I'm ready for your questions.
Thank you very much, Dr. Falconi. There are some questions
Yes.
Let's start from Stephanie. How long do I have to wait to treat the horse after the tendon injection, IRP or PRP or others?
1 week.
1 week.
1 week. Yes.
Okay.
I prefer to wait 1 week because I want to be sure that there is no interaction between the injection and the laser, because laser is light and can interact with the molecules. So I don't want that this happens, because I cannot be sure what is then the effect on what I have injected.
There is another question. Why no laser therapy for 1 week after the PRP or stem cells?
Yes, I answered just now to this
Okay.
question.
So I was focused on.
Yes.
Okay. For insertion.
Sorry, Roberto, it's the same if I use also corticosteroids in the joint. I cannot use laser therapy for 1 week. It is the same reason, because there is always an interaction with light on the molecules. So I don't want this. And studies showed that after 1 week, these molecules are not so present as at the time of injection. So it's that the reason for this timing.
Okay. Another question for Marie. For insertion suspensory ligament, for example, the 3 programs that are done on the same day, which time for each program? Edema, acute tendinitis, bone injury?
Okay, I treat only 1 time a day, and I can put more protocols one after the other. I don't make the, 1 protocol in the morning and 1 in the evening, not at all. I do the protocols one after the other. In the insertion of the suspensory ligament, I can add also the protocols for fracture, that is 73 Hertz, which is the protocol very useful where there is an insertion on the bone. So I don't want to treat only the ligament, but also the insertion on the bone.
Okay. Are eyes, the acute desmitis and tendinitis disturb the effect of the laser treatment, the eyes?
Not at all.
Not at all.
Not at all. No.
I mean, it can increase also the range of action of the laser if you cool down the area. Yeah.
Yes, in acute phase, it's very important to cool, and so there is no interaction. What I can say, if the leg is still very wet, then in some cases, it could be that the light is much more stronger than what we expect. So if it is possible, try the leg before using the laser.
There is a technical question, and for this reason, let me review a little bit the presentation, because I need a slide. Because one participant's asking what is the difference between Cpw and Fw, and for this reason, let me go to the slide. Ecco qua. Okay, so basically, what is the difference between Cpw and Fw? Most of the protocol are set in the FBW. What does it mean? We are in this modality, in the modality on the right. So basically, the modality on the right, there are packages composed by pulses and continuous wave, okay? And the frequency that you see in the protocols is how many of this package we send in 1 second, okay? When we use CPW, we are in this modality, in the first one. So basically, we have still the train of pulses, but the continuous emission is on all the time. Usually, and in this modality, we double the energy that we provide, okay? Usually the indication is, but I will ask also Dr. Falconi for his impression. The indication is to use the frequency modality to approach most of the pathology, especially in the acute situation, and to use the Cpw in case you have a strong chronic situation or not response from the FPW. Right,
yes.
Dr. Falconi?
Yes, but if you cannot use the continuous wave too much, because it's not useful to give too big amount of energy. If I have a chronic situation, for example, in a tendon, and I could not see the horse before, and they show me the case and it's already in a chronic situation, I start stimulating the structure with the continuous wave, but I do it just once. And then I can see after 2 weeks if I need again a big stimulation. Otherwise, I will use the protocols with the frequencies.
Okay. There is another question. Do you always have good result in very chronic tendon lesion, even with calcification? For example, if you see the affected patient after weeks or months for the first laser treatment?
Okay, in this case, it depends, because in very chronic situation, we have already a reparative process that started, and if we have fibers and collagen fibers that are not in the right position for the strength of the tenon, I cannot change this with the laser. But what I can do is to reduce the inflammation that there is still in the structure, and to help from that moment on. So if I have a calcification, around the calcification, there is always a point of inflammation, because it is a point where there is no elasticity. So with the laser, I can reduce the inflammation around the calcification, and in a certain way, I can help anyway to the chronic situation. I cannot reduce too much the diameter of the structure if I see the horse the first time when the situation is already very, very from a long time. So if I see it after 1 year the first time, and they show me a big tendon, and they ask me, can you do something? Okay, the result will not be so great as if I can start from the very beginning of the lesion.
Okay. There is I like this question. For which kind of treatment do you prefer point-by-point modality over continuous wave treatment? I guess he mentioned, he mean scanning modality.
Scanning modality. Yeah. So I prefer point-by-point modality, first of all, because I know exactly how much energy I give in each point, and this is very important to me also when I record what I did. And so I prefer on these structures the point-by-point modality. Sometimes if I already did 2 protocols and I want to make another one, the last one will be the protocol for edema. And I don't want to give so much energy in the same point for too many times, then I can use the scanning modality as to finish in a certain way my therapy for that time. But normally I prefer the point-to-point modality, because I'm sure there is no risk of damage, and I'm really sure what I'm doing in this point.
So basically, to be sure how much energy you provide in that point. Yeah. Exactly. I don't see any other further question. Okay. Thank you very much for your time. And just to remind you that the next module, the next webinar, the number 3, will be on the 15th of December. Okay, just before Christmas. So we we will say Merry Christmas to everybody. And the topic will be joint condition. So see you on the December 15 at the same time. And I wish you a great evening. Thank you very much, Dr. Falcone.
Bye.
Bye-bye.
Bye. Bye.